For a lot of the women where testosterone does help them, it's because they're using excessive amounts that are going to have other types of side effects too.
You feel like you want to have sex and all of a sudden you have like a beard and all this stuff going on. Welcome to the Modern Menopause podcast. And this week, the myth/BS that Robyn and I are tackling is, does testosterone fix all your libido problems in perimenopause and menopause? So one of the most common things that we hear from our customers, and it's pretty viral right now on social media, is that if you're in perimenopause and you're in menopause and your libido's taken a wee bit of a nosedive, then slathering on some testosterone, getting some testosterone shots, testosterone pills is going to be this magic bullet. We hear this a bunch. Dr. Robyn, I'm sure you hear this a bunch. So let's take a deep dive into this because, you know, I think that there's a lot more to it with women's libido, certainly.
Yeah, definitely, Morven. And I wish we had something so simple as just take some testosterone and your libido is going to come back. This is probably one of the main complaints that women have in the perimenopausal years, is as their libido wanes, whether that's creating stress for them, their relationship, they think it's creating stress for their partner. But unfortunately, it's not as easy as here, use this testosterone, you'll get your libido back. And you know, for a handful of women, it is. You know, they use testosterone and everything's, you know, better and libido's, you know, back in action again. But for most women, that isn't the case. Libido is what we call multifactorial, meaning many different things play a role in it, especially for women. So, yes, it can be waning testosterone, but it can be other hormones, estrogen, progesterone, DHEA. One hormone that it often is that we don't think about is cortisol, which we can talk more about, but we can have changes in our baseline cortisol. I'm not talking about stress response here. I'm talking about baseline cortisol levels and what we call HPA axis dysregulation. Most people don't say that, but that's its, you know, true name. But it can be other things too. You know, think about this time of life. Women oftentimes are juggling maybe multiple roles. They've got teen kids. They've been in long-term relationships. Maybe there's some relationship strife. Maybe they're handling aging parents and there's a bunch of stress involved. Medications play a role here. This is the time of life where women are prescribed the most antidepressants, or most frequently. And whether, you know, I'm not saying that's good or bad, but those medications, they're one of the main side effects can be low libido for women. So we have those types of things that play a role. And then our bodies are typically changing in this time. You know, there's some average weight gain there. Maybe there's new belly fat they're not used to. And so they're starting to perceive themselves differently, as well as question who they are in this new part of life. And so that confidence might be lacking that they would normally bring to their relationships, and that can play a role. And there's other things too, but we have to realize it's not just testosterone. And for a lot of the women where testosterone does help them, it's because they're using excessive amounts that are going to have other types of side effects too. So libido comes with it, but you know, maybe they get some unwanted facial hair growth or acne or scalp hair loss or even voice changes with it.
You feel like you want to have sex and all of a sudden you have like a beard and all this stuff going on. Okay, well, because I think you raised a really good point there, right? Which is there's all these environmental, in therapy, we'd call it like context factors, right? You've been in a long-term relationship, you have a bunch of work to do, you have a bunch of chores, you've maybe got kids who are teenagers, it's sort of transition years, it can be pretty stressful for parents. There's a lot going on. So there's all these outside factors which are maybe messing with cortisol. So it does kind of have a hormonal link, but these are sort of outside factors that can be challenging. Maybe there are less date nights, maybe there is less conversation about what sex looks like now. But the other factor, right, is you mentioned there's a bunch of different hormones that can play a role. Because I think, certainly on social media, but I think in general, right, is we do get this message that testosterone controls sex drive. And actually, there's a bunch of other stuff going on. And so I think that would be interesting to talk about, right? You know, we hear from a lot of ladies who are using our Silky Peach estriol cream. So I think it might be a good idea to go through these hormones and take a wee look at, okay, well, what is each hormone doing for women when it comes to their sex drive? So if we look at, say, estrogen, estriol, what role does it have on our sex drives, on our libido?
Yeah, huge, actually. And by a couple different ways or different factors here. So, as we're transitioning into menopause and our estrogen levels are fluctuating and declining, we lose the estrogen at the vaginal tissues, which can result in pain for women. We have dryness, we have thinning tissues. It can just make sex uncomfortable. And so, obviously, if sex hurts, that's not going to be something we seek out, right? The brain's like, no, thanks. Let's not do that today. And what happens is if that isn't addressed right away, it creates kind of a pattern in the brain that we learn it and we have to unlearn it. So just because maybe we're able to address that pain with vaginal estriol, and we can talk about the difference on estradiol and estriol, but let's say we address that pain and the pain goes away, it doesn't necessarily mean libido comes back right away because we've associated now sex with pain. And so there has to be some unlearning there for women.
Okay, so you bring up an interesting point, right? Some women are saying, okay, I'm in pain. I treat the pain with the estriol cream with something like Silky Peach, and then the pain's treated. I can have sex again. Great, my libido's been fixed. But in reality, for those women, their libido is never really gone, right? They treated the pain. They could have sex again. Fantastic. For some women, it's slightly different. They treat the pain, but they still have that psychological aversion. They maybe even have physiological aversion. They have vaginismus or things like this, where they still don't really want to have sex. And so that libido starts to flag. Anything else that might be going on for women with estrogen or in this kind of environment?
Yeah, absolutely. So estrogen, besides supporting the vulvar and vaginal tissues, it works all over our body and our brain, other tissues, heart, all that stuff. But one of its roles is to help serotonin be produced. We all know serotonin as like our happy little neurotransmitter. It's what most of our antidepressant medications work on. And as estrogen levels decline, serotonin levels can decline. And we need adequate serotonin to help with libido as well. Not too much and not too little. And so as that's changing, we're seeing, not only changes in serotonin production, but its availability and how receptors bring it into the tissues. So it can actually be helping on that type of level as well versus just tissue levels.
Nice. Yeah, that's an interesting one because I think that we don't necessarily think about what's going on at the brain receptors or the cognitive level with our sex hormones. I think it's right. Again, it's a failing of the education system, right? Which is a much bigger topic for another day. But people think of sex hormones and they think, boobs, balls dropping, facial hair, libido. They don't think, hey, it's doing stuff in my brain. It's doing stuff in my body in other places, which I think is where progesterone kind of comes in, right? Progesterone is this quiet, subtle superhero who's doing all this stuff behind the scenes. What's progesterone doing for libido?
Yeah, great question. It does not get enough press here, but progesterone helps us with what we call partner receptivity, or how we receive our partner when they make a sexual advance. And as we're perimenopausal, we're making almost no progesterone. And in our conventional approaches to hormone use for women, progesterone really is just used to protect the uterus. So, some women aren't getting any, they're not getting enough. It's just being ignored. And so we have that part of it, but also as progesterone levels are declining, it's kind of like perpetual PMS. And if we're feeling bitchy and bloated, that does not equal sexy,
sure.
right? So there's, how a woman's feeling on the inside too, that's helping to address when we have sufficient levels.
Sure. That's usually the low point. You're like, okay, I feel like shit. I'm bloated. I feel disgusting. Right. Your partner tries to hit on you and you're
Please
sort of like,
away.
Okay, let's gonna skip that one for sure. Okay, so it's sounding from what you're saying like estrogen has this role in vaginal health, right? In vaginal tissue health, in vulvar tissue health, but it also has this big role on serotonin and our neurotransmitters. And progesterone kind of leans more into that. It's helping us feel more like ourselves. It's helping our bodies feel kind of, I guess, more physiologically close to our baseline, or our baseline that feels good. What about DHEA? Because DHEA is a less commonly known about hormone. I think that, we don't really hear about it. We don't really know about it. It also functions slightly differently from things like estrogen and progesterone, right? So what does DHEA do? What role does DHEA have in libido?
like you said, DHEA, we could call it like a newer hormone. It's not new. Obviously, we've had it forever, but it's newer to medicine and discussions. And as a woman is becoming menopausal or has become menopausal, this serves really as the building block for her hormones. So we make most of our estrogen, and most of our testosterone from DHEA. It's what we call a pro-hormone. But as we age, and definitely by the time we're menopausal, DHEA levels decline. And so this building block that we need to make these hormones has declined. So we can't make them, our bodies can't make them as efficiently as we once could. And what's interesting is there's this idea that postmenopausally we don't make hormones, but it's not actually true. The ovaries don't participate as much as they did, but we're making more hormones in our fat cells. Now, same levels as before menopause? No, but we can make hormones there. And by supporting the building block, it can help support kind of those downstream hormones like estrogen and testosterone.
So this is where we start to see that multifactorial element to libido, right? We have all these context factors about perimenopause and menopause as a stage in a woman's life. I think there's probably also the social element as how women are viewed at that stage of life. But again, that's a bigger conversation than we have time for. But then we're seeing even hormonally, right? There's a multifactorial. There's multiple different hormones involved. I want to get into cortisol, but before we do, let's talk a little bit about testosterone and also how men and women's libidos differ, because I think that's a big part of this conversation, right? For men, boosting testosterone is going to have a fairly straight line to boosting their libido. But what does it look like for women? Because you said this at the beginning, right? Yes, some women are going to take testosterone and they are going to have this result. They are going to boost their libido. But that can often come with some pretty risky side effects. So let's take a look at that and how that picture plays out for women is, okay, my husband takes testosterone, bam. The next thing I know, he's poking me in the back at 4 a.m. every morning. I take testosterone, what happens with me, right?
Nothing happens. Right. Yeah, no, that's a great question. Part of this comes down to like who needs testosterone. We don't have universal criteria for what women should be getting testosterone. Like what do their levels look like? Who need it? What should our levels be? We as a medical community have not agreed on that for men, let alone for women yet. So it's kind of the wild, wild west of testosterone use out there right now. It's like, you try this, and there's really no standard. So it's hard to say what woman is going to respond because we don't have a standardization there. But if I would suspect that a woman who has a better chance at responding to testosterone use is going to be somebody with lower levels, lower total levels, lower free levels, things like that. But what's interesting, there was a study that was done, I often refer to, where it was performed on women who had bariatric surgery. So these women were what people would consider, or what medicine would consider, overweight, and they had weight loss surgery. And they measured their testosterone levels before surgery and after surgery. And their levels came down and their libidos went up. So it's so important to realize that testosterone is not directly related in that linear effect for women that it is for men, because it is multifactorial. Women are more like crock pots. It takes a while to warm up. It's many things. It's going to take a while for us to be ready for that intimate encounter, whereas men are more like microwaves, like, oh, okay, ding, I'm ready.
Right.
I don't mean that crudely, and it's not, of course, 100% true across the board, but it's pretty common. So it's the testosterone piece itself is really interesting because we don't have a standardization, and that comes to using it as well. There is no testosterone available on the market for women that's like FDA approved right now. That's like, oh, use this dose this often in this amount for women. So what's happening is women are using men's preparations and not measuring them. So this is a really common approach I see, is like a woman getting a men's preparation from a pharmacy and being told to just use a pea size amount. Well, is that a dry pea? Is that a fluffed up pea? Is your pea the same size as my pee? There's no measuring. And it ends up that when we're trying to use meal preparations, women are getting doses well beyond what their bodies would normally make. And so when that happens and we're pushing that envelope, and it's like, we make about 1 milligram a day. And so If that's the case, and, men make about 10 milligrams a day, but women are being given upwards of 10 milligrams or more per day. And so what we see is, maybe libido is going to come back with that. But for a lot of these women, at least a lot of the women I've worked with, there's also going to be scalp hair loss. And then they get a new med to block the testosterone, so there's no scalp hair loss. Or there's acne, and they get a new med for the acne. Or there's facial hair growth. Or there's deepening of voice. I've seen that too. And there's, there might not be coming back from those things. So if we are using it, trying to work with a provider who can understand like the actual physiologic dosing for women, which is around 1 milligram a day, sometimes a little more, sometimes a little less, but so just some considerations there when it comes to testosterone and women's health.
Okay. Yeah. Because I think that's sort of the big thing, right? Is people are seeing stuff on social media where someone is taking testosterone and they're like, I feel amazing, or it did XYZ. Yeah. And there's no basis. It's not like, hey, I'm using this product that has X amount in it. It's like you say, the wild, wild west is a good analogy. There's a bunch of different stuff out there. They all have different levels. And sometimes you're seeing people in the early phase of treatment before things like the scalp hair loss or the acne kick in, where they get this boost because their body does maybe need it because their levels are low. Lo and behold, give it a few months, all of a sudden, oh, hey, things aren't always necessarily going the way that I had hoped. Okay.
Yeah. Well, and maybe that social media person, that we're seeing that did get the big boost and it worked for her is because her levels were lower. But what can actually happen when some women are going to have higher levels, whether that's because they're really muscular and they just lean towards more testosterone, their bodies make more, or in an insulin resistant state, especially in younger women before menopause, our available testosterone can actually be higher. So if we give somebody like that testosterone, it's not going to help. In fact, it's probably going to exacerbate some of her other symptoms.
We're going to take a pause to remind you that one of our missions is to spread the word of perimenopause and menopause with as many ladies as possible. So if you know someone who might be struggling with this same issue or these challenges, now is a great time to share this podcast episode with them. So we've looked at some of the major kind of sex hormones, right? But cortisol, we mentioned this at the beginning, and cortisol obviously really dovetails with context factors. So tell me a little bit, tell our listeners, what role does cortisol have here? What's happening when we do get, HPA axis dysfunction or adrenal fatigue, as is the sort of more commonly known name, with libido?
This is honestly, if I had to pick one hormone that was probably affecting libido for women and wonder who was going to get, put my bets on who was going to get better if we address that hormone, I would look at cortisol for most folks. And so cortisol kind of gets a bad rap in social media right now. I see all this stuff that's like cortisol detox, do this to lower cortisol, do this to lower cortisol. And really what we want to do is we want to replace the word cortisol in that context with stress. Let's do a stress detox. Let's do, lower stress levels, stuff like that. Yes, our body does increase cortisol when we are stressed. However, we have a baseline cortisol curve. We can think of it as like our gas tank. We all need cortisol. It's required for life. We don't want to decrease our baseline cortisol typically. It's anytime we want to do something, we have to pull from that gas tank. So cortisol is not all bad, even though it's kind of made out to be the bad guy. We actually really, really need it. We would not be here without it. I can't emphasize that enough. But then what happens is when we're stressed, our brain tells the adrenal glands, the glands that make cortisol, to make more of that hormone. Stress goes away and we go back to baseline. But during chronic stress, there's increased demand. Make more. Oh, stress is still here. Keep it coming. Oh, new stress. We need more of that. And the body doesn't get the chance to go back to baseline and get that rest that it needs, but it can't keep up with the demand. And so what happens is that system becomes a little dysregulated. And when it becomes dysregulated, our baseline cortisol curve changes. When our curve changes, that's when we become symptomatic. And with time, what happens is this curve that's supposed to be nice and robust in the morning and kind of come down throughout the day, it would mirror our energy levels and our sleep-wake cycles, it with time becomes lower. And when it becomes lower, we become tired. It's really hard to do things. We can't get off the couch. Maybe, we exercise, but now instead of feeling energized, we feel fatigued and we need a nap. We start to lose our motivation. We're more irritable. Stress feels bigger than it is. We're quicker to snap. We lose our patience. Maybe sleep is more difficult. And so think about feeling like that. We're so tired, there's no energy left for sex. Our brain sees sex as procreation. It's to make a baby. And so if we're too tired to get off the couch and do anything but watch Netflix, why, it's like, like a light switch. No thanks. Why we can't take care of another being. So it's just kind of, turns off. And so this system, by working the context around it, when we're addressing it, can be really helpful in restoring libido. And it does not get enough, I don't think it gets, enough attention. And I think you've even found recently a great study article on this, and there's entire books written on this.
Yeah, and it kind of ties back into everything, right? Like you're saying, is cortisol gets this bad rap, which is something that we're going to cover in another podcast in more depth. But it does, yeah. People, they're trying to lower their cortisol. They're trying to change it. They think something's gone wrong. And, to some extent that is true. There is often dysfunction, but that dysfunction feeds back into a lot of those context factors. Like you mentioned, people's bodies are changing. They're maybe not sleeping well, but they're too tired to go to the gym, which would help their mood, which would, help with their self-confidence. And so it becomes this loop of there's all these context factors, then there's all these hormonal factors, and they're both kind of feeding into one another, which I think is sort of the challenge with women's libido. We're going to switch over to some questions now for Dr. Robyn. All of our Modern Menopause podcasts include some questions from real customers, real ladies who've reached out to us who are struggling with some of the things that we're talking about each week.
Sure, okay. Let's do it. Pen and paper in hand. Okay.
Do your products work if your hormones are so low that you've lost the sex drive? So we have a lot of customers who are using our products, and they're seeing relief. They're seeing a lot of great results, but they're saying, hey, what else can I do for my libido? I'm taking the Silky Peach. I'm using the Vibrant Third. Maybe I'm using DHEA. I'm using the Rebounce. Or we have people who reach out to us who are saying, hey, I'm using the Vibrant Third, but I can't use any estrogens because of cancer risk or medical history. What else can I use? And I think that this is the big question is, we would always say to our ladies, hey, get your saliva tested, see where your cortisol's at, check your stress levels. But what about for the women who are doing those things? What else? And obviously, I have thoughts on this as a therapist of saying, okay, well, there are other factors relationship-wise you can do. But again, that's sort of personalized to people's relationships. Are you guys dating? Are you guys enjoying intimacy that's not just sexual intimacy? Are you talking about what sex looks like, about body changes?
Do you like each other still?
Do you guys still like each other? Do you guys still spend time together? Is there still, do you spend enough time apart? Oftentimes when both people retire, it's the opposite problem. It's we're not doing enough of our own thing to kind of come back together.
Yeah.
Are we communicating well? Outside of those factors, right? Outside of, hey, are you managing your stress? Are you doing things that make your body feel good? Doing things for your confidence? Are there other products I can use? This is sort of, I would say, the biggest other question we get about libido.
Yeah, I mean, there's a couple things. I have a group of things that I consider key nutrients. So hormones are great, and hormones are going to, help us with so many things. But if we are lacking in some of our key nutrients, it's going to be a struggle to make some of those neurotransmitters that help us with our drive, help us passion, desire, drive, all that. Things like serotonin, dopamine. So these are really simple things that can be tested and addressed if needed. So people can go, they can ask their providers for this testing. They can do it through, a lab where they can go do direct to patient, but simple things. So I think of vitamin D when we are making serotonin or dopamine. Dopamine's our drive neurotransmitter, drive, passion, sex, fun, and serotonin we talked about earlier, also required here. The very first step in making these neurotransmitters requires vitamin D. And so if that's deficient or low, we've already kind of shot ourselves in the foot there. And a lot of people make the mistake of stopping their vitamin D supplementation in the summer because the sun's out. But for most people, myself not included, if we do not live, most people don't live close enough to the equator to make enough sufficient vitamin D unless they're outside, 2 hours a day, 90% naked, which most of us aren't doing.
Maybe if you're trying to get your libido back.
I mean, who knows? Vitamin D. Next step requires iron, B12, and folate in that process of making those neurotransmitters. So iron is something that's overlooked in our perimenopausal, but specifically in our postmenopausal population. And it's thought that when a woman stops bleeding, her iron levels are going to be fine. And I'm not talking about anemia here. Anemia is what's seen in our red blood cells. If someone's gone and donated blood and told their iron's okay, they're not looking at your iron, they're looking at the red blood cells. So I'm talking about actual iron stores, which is something called ferritin. But as we age, we lose our stomach acid. Stomach acid is required to absorb iron. So what happens is, women don't get this level tested because they're no longer bleeding, so they must have adequate iron. Not necessarily the case. Maybe they're not absorbing it. Maybe they're using it more than it's coming in. So ferritin's a key nutrient. And like I said, B12, same concept with B12. As we lose our stomach acid or it starts to downregulate, then it's harder to absorb B12. And folate. Folate is really high in processed foods diets. And I'm not telling anyone to change to a diet high in processed foods, but if we're following like a whole food plan, folate levels can be a little lower too. So I think about supporting that so our bodies can make these neurotransmitters effectively, or at least have the best shot at it, right? That's one thing. Practicing mindfulness. We talk about stress management, but I think a lot of people have different ideas of what that is. And so just spending a couple minutes a day where we're not thinking about our responsibilities. We're just present in the moment, maybe doing some breathing, counting the leaves on a tree outside, and just not thinking about the stressors. That's taking our body and putting it out of our stress state and into our rest state. Deep breathing, like you said, doing things that help our bodies feel good. So it's eating enough food, not skipping meals, drinking enough water, getting adequate sleep, which is often hard at this time of life. But so things along those lines too that can basically help support cortisol levels and keeping our body in a less stressful state and more restful state. And I think there's key things that people can do in their relationships too. Like you mentioned, maybe they're not getting enough date nights, and just putting that on the calendar and going into it with no expectations. Maybe just, going for a walk and holding hands. It doesn't have to be something fancy where we drop $300 to go to a fancy dinner or something, just quality time.
Yeah, I think those are good things to think about, right? Is that nutrient part, again, it sort of all circles back to, I think is a challenge for a lot of women, right? As their bodies change, as lives change, is that there isn't a magic bullet for libido. There's certainly a bunch of different things that can help. And unfortunately, women, they don't hear about these things. They don't know about them. And so they make that it's a really logical step, right? For women is, hey, my libido is struggling. Maybe testosterone will help. And I think that it's interesting to hear this other side of it, which is, maybe testosterone will help, but actually there might be a whole bunch of other things. And I think that this is a really important thing for our listeners to hear, is all these other things are going to help with more than just your libido, which I think is the big part of it. Is iron going to help your libido? Yes. It's also going to help a bunch of other things. Is progesterone going to help your libido? Yes. Is it also going to help your sleep, your mood, your brain fog? Yes. There's a good chance that when you start balancing out these other things to bring that libido, a bunch of other areas are going to get better. You have that wonderful domino effect in the right direction, where the dominoes are all coming up good. So that was great. I appreciate you answering all those questions, Dr. Robyn. For our listeners, if you have questions, drop them in the comments. If there's other kind of BS myths, claims, stuff that you hear about perimenopause, menopause, and you're thinking, can that be true? Is that real? Is this going to help me? Let us know in the comments. That's what we're here to do, is take a look at some of these myths, these claims, and say, do they have the science? Is this going to help our listeners? Thanks for listening in. That's all we have time for today. But if you know anyone who might be struggling with this, or someone who's looking to have a hot date in the near future and this has been a challenge for them, be sure to share this with them. If you enjoyed it, be sure to subscribe, and then catch us next time.